Musician and conductor Clive Wearing was at the height of his success in 1985 when a virus completely destroyed the memory part of his brain, leaving him trapped in a limbo of the constant present as his memories fell apart. Narrating his story in the memoir titled Forever Today, his wife, Deborah Wearing, wrote that for several weeks he had suffered with intermittent headache and mild fever, which they had ascribed to hard work and exhaustion. However, on awakening one morning, he said the headache he experienced was like something hit me with a hammer all over. It was constant and it kept him awake for 3 days and nights. His temperature also soared and he was vomiting. He then gradually developed memory difficulties, first forgetting his wife's telephone number and then her name. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast. In this episode, we will be exploring the subject of amnesia, the isolated loss of memory. We are starting with the story of Clive Wearing, as it vividly illustrates the manifestations of amnesia as well as one of its most common causes. As Wearing's condition progressed, he became confused and struggled to understand simple instructions. At its peak, he wandered out of the house and couldn't remember his address when he hailed a taxi to take him back home. On returning home, he could neither recognize his building nor his flat. He then started slipping in and out of consciousness, the final symptom that triggered his admission to hospital, where he went on to develop convulsions. Wearing's doctors suspected that he had herpes simplex virus type 1 encephalitis, that is, a viral infection of the brain substance. He was immediately started on acyclovir, the antiviral medication that Deborah Wearing said had only been on the market 18 months and without which she said he would certainly have died. He had a CT scan which she said showed his brain had been virtually mulched by the virus. A year later, when he had an MRI scan, many brain areas were seen to be affected, but particularly the hippocampus, which was completely destroyed. Wearing, however, noted that as damaged as Clive was, the musical part of his brain was unaffected, as was his passionate love for her. As he recovered from the infection, she said his speech was a jumble. He could not understand what was said to him and he could not communicate. She added that his ability to speak a coherent sentence and to register what was being said to him was gone. She added that no matter how many times he asked, he was unable to take in and store the answers. Every question was the first question, and every answer was news to him. He went on to develop confabulation, which Deborah Wearing explained is when an amnesic person is unable to furnish much real information about his life and he unconsciously expresses something made up. Reviewing the profundity of his memory impairment, she said Clive was unable to remember anything for so much as a second, adding that he had amnesia so all-encompassing it erased everything instantly. She added that he seemed to be lost to ordinary consciousness and to be existing in the deepest, darkest pit, not able to get out of that hole and live in the world where we lived. He appeared to be unreachable. She concluded that Clive was under the constant impression that he had just emerged from unconsciousness and his present instantly erased, his past void, and he had only the vaguest sense of autobiography. In spite of his severe amnesia, however, she said he still retained his fundamental intelligence. Clive Wearing's case reveals just the tip of the iceberg of pathologies that can result in the curious phenomenon of amnesia. Let's take another example as illustrated by the remarkable case of Jimmie G, a 49-year-old man with a curly bush of grey hair, whose case was narrated by Oliver Sacks in his classical book titled The Man Who Mistook His Wife for a Hat. Sacks described Jimmie G as charming and intelligent, but memoryless. Whilst he could recollect his early life story vividly, in detail, with affection, Jimmie G nevertheless thought that he was still 19 years old and that he was still in the Navy. And he panicked when he looked at his image in the mirror, unable to recognize himself in it. Sacks explained that Jimmie G had an extreme and extraordinary loss of recent memory, so that whatever was said or shown or done to him was apt to be forgotten in a few seconds. Jimmie G had no recollection of conversations he had just a few minutes ago, although, Sacks said, he sometimes retained faint memories, some dim echo or sense of familiarity. But he performed excellently on tests of intelligence. Sacks said he was quick-witted, observant, and logical, and he had no difficulty solving complex problems and puzzles. Echoes here of Clive Wearing. Jimmie G was manifesting severe amnesia as a part of Korsakoff syndrome, a disorder of thiamine or vitamin B1 deficiency, which most frequently accompanies chronic alcoholism. But Korsakoff syndrome could also result from nutritional, toxic, and metabolic disorders such as chronic infections, diabetes, as well as poisoning from lead, arsenic, or carbon monoxide. It is also possible that there is a genetic predisposition to Korsakoff syndrome. People with this disorder, such as Jimmie G, are alert and responsive, but have marked impairment of memory and the ability to learn new things or information. They therefore repeatedly ask the same questions and read the same page for hours. They are unable to recognize people they recently met, but their implicit memory for performing tasks is preserved. The MRI of people with Korsakoff syndrome typically shows lesions in three parts of the brain: the mammillary bodies, the mammillothalamic tract, and the anterior thalamus. This is for the neurologist. Korsakoff syndrome may be preceded by a more acute disorder of thiamine deficiency called Wernicke encephalopathy, but this is often not the case. People with this condition also have amnesia, but unlike in Korsakoff syndrome, they are also confused. When examined, clues to the diagnosis of Wernicke encephalopathy include impaired eye movements called ophthalmoplegia and abnormal eye movements called nystagmus. They may also present with impaired hearing, impaired vision, as well as impaired sense of smell. For another dimension of amnesia, let us go back in time to the 25th of August 1953. This was when Henry Molaison was a 27-year-old man about to go under the knife of neurosurgeon William Beecher Scoville. This was an operation that would set in motion a process that would make Molaison the most important patient in the history of neuroscience. When he was just 10 years old, Molaison had developed daily partial seizures, the result of a minor head injury he sustained in a bicycle accident. When he was 15, his seizures had progressed to grand mal convulsions. Narrating his story in her book titled Permanent Present Tense, psychologist Susan Corkin wrote that Beecher had failed to control Molaison's epilepsy by conventional anti-seizure medications. He therefore resorted to an experimental operation neither he nor any other person in the world had dared to perform before. Beecher, an advocate of psychosurgery, had performed operations on people with schizophrenia, but never in people with epilepsy, and never on both sides of the brain as he did with Molaison. Psychosurgery had been introduced by the Portuguese neurologist Antonio Egas Moniz, for which he won the Nobel Prize in 1949. The operation Beecher carried out on both sides of Molaison's brain was called a medial temporal lobotomy. This extensive surgery included taking out many parts of the temporal lobe, including parts called the uncus, and the front half of the hippocampus, the amygdala, and the entorhinal cortex. This for the anatomists among you. The consequence of this radical surgery is that it cured Molaison of his epilepsy, but it left him with permanent amnesia. Why did Scoville opt for this radical treatment? This is not clear, but in his biography of Molaison titled Patient HM, journalist Luke Dittrich gave an insight into why Scoville, his grandfather, settled on the riskiest possible procedure, something he said no other surgeon would have opted for. Dittrich believed that this was because Scoville was both ambitious and a risk taker. Corkin, she was also the psychologist who studied Molaison the most, wrote that in the decades after his operation, he lived in a permanent present tense. He could no longer remember the faces of people he met, places he visited, or moments he lived through, adding that his experiences slipped out of his consciousness seconds after they happened. Corkin also wrote that Molaison's surgery had freed him from the moorings that anchor us in time, and he had become unencumbered by recollections from the past and speculations about the future, and he always lived in the moment. I can see good and bad sides of that. Corkin also explored what Molaison's case taught neuroscience. She said, through Henry's case, we gained insights that allowed us to break memory down into specific processes to understand the underlying brain circuits. For example, it was his case that she said taught us how memory does not reside in one spot in the brain, and that the medial temporal lobe structures were important for long-term declarative memory, and this is the conscious retrieval of facts and events. With the most profound amnesia documented at the time, Corkin said Molaison gradually became the yardstick against which other amnesic patients were judged. He also became the gold standard for the study of amnesia because, presumably, his operation did not cause any cognitive deficits other than amnesia. This assertion that Henry had no cognitive deficits has, however, been disputed, such as by Donald McKay in his book titled Remembering. He based his book on his account of the 25 studies he carried out himself on Molaison. McKay stridently argued that Molaison was not a pure amnesic, but that he also had problems with speech and with language. He asserted that his research showed that Henry could neither comprehend uncommon words, nor read them aloud, nor spell them correctly. McKay's perspective of Molaison simply goes to show that brain functions are too complex to confine to specific brain areas. Beyond the classical and iatrogenic or physician-caused disorders that manifest with amnesia, there is a long list of other diseases that do the same. Let's take the case of Sue Meck as an example. In her illness memoir titled I Forgot to Remember, we learn that Meck's problems began after she had an unwitnessed head injury on the day she said, "My old life ended and my new life began." Her husband Jim was with her in the kitchen with his back turned to her when he heard a noise and turned to see her losing consciousness and collapsing to the ground with blood flowing from her head. The assumption was that the fan had fallen and hit her on the head. On recovering, Meck neither knew her name nor who she was. She also didn't recognize her husband or her children, although she had transient recollections of some people. She was also unable to use a hairbrush or drink from a cup. Her long-term memory deficits were profound, as she had no recollection whatsoever of the events of her whole life. These are called episodic memories. But her memory of facts and knowledge, called semantic memory, and some procedural memories such as speech and walking were preserved. Meg explained that the accident didn't just wipe out all my memories, it hindered me from making new ones for quite some time, adding that I awoke each day to a house full of strangers. The head injury also totally altered her personality, and she portrayed this when she said, "The two Sues have lived separate lives. She rebelled, I conform. She broke rules, I follow them. I like vegetables, she hated them. She loved to swim. I'm absolutely terrified of the water." The possibility that Meg was manifesting functional or psychological amnesia was also explored by her doctors. They, however, concluded that this was unlikely because her anterograde memory for the events that she experienced after the head injury, were also affected. Unlike the remarkably persistent cases of amnesia we have reviewed so far, the types of amnesia that a neurologist is likely to encounter in clinical practice are more fleeting, even though they are equally dramatic. And the most frequent of these is called transient global amnesia, or TGA for short. TGA is a fairly sudden loss of the ability to lay down memories, and its clinical presentation is classically with repeatedly asking the same questions, but without any confusion or loss of personal identity. TGA may be triggered by such circumstances as powerful emotional or physical experiences, contact with cold water, orgasm, exhaustion, and a diverse range of medical procedures such as angiography, anesthesia, and cardiac catheterization. TGA episodes typically resolve within 1 to 24 hours, although about 3% of cases last under 1 hour. The neurologist needs to consider several mimics before making a diagnosis of TGA, and these include migraine, seizures, which manifest as transient epileptic amnesia, as well as transient ischemic attacks, concussion, alcoholic blackouts, and the effect of treatments such as benzodiazepines, zolpidem, and even electroconvulsive therapy. A test that is almost always required to ensure that one is not dealing with a typical TGA is an MRI brain scan. The MRI is often normal, but it may show small punctate or dot-like lesions in the hippocampus on the MRI sequence called diffusion-weighted imaging, or DWI. These lesions are called hippocampal punctate DWI lesions, or HPDL. That's for the neurologist among you. Beyond the disorders we have discussed so far, there is a host of other neurological diseases that can manifest as subacute or chronic amnesia. These include benign senescent forgetfulness, Alzheimer's disease, frontotemporal dementia, spontaneous intracranial hypotension, depression, called pseudodementia, fugue states, brain space-occupying lesions, and obstructive hydrocephalus. Subacute amnesia can also result from systemic disorders such as cardiopulmonary arrest, acute respiratory failure, drowning, and strangulation. There's also a long list of other disorders that manifest as acute amnesia, and these include stroke, multiple sclerosis, autoimmune encephalitis, acute toxic metabolic disorders, and influenza infection. Use of substances such as ecstasy, as well as medications such as lorazepam, can do the same. In the next episode of this podcast, on the theme of amnesia, I will be speaking to Lauren Aguirre to discuss her book titled The Memory Thief, which explores an emerging cause of acute amnesia called opioid-associated amnesic syndrome. Thank you so much for listening to or watching this podcast in which we explored amnesia. If you found this podcast enlightening, you may consider subscribing to NeuroChecklist, my online database, for more neurology of amnesia. And you may also wish to explore the lighter side of neurology in my book called Surfing the Brain. And why not subscribe to the podcast, iTunes, Spotify, or or YouTube channels to ensure you do not miss the next episode of the Neurology Lounge podcast. Thank you very much for your time.